All right. Good morning, everybody. Dr. Arrhythmias here, Vet Triage. Wednesday, September 25th, 7:58 a.m. Pacific Time. We are going to talk about heart disease in dogs. So right off the bat, two things. Number one, this article, which comes from this issue of JAVMA, boom, to December 15, 2017, was actually written by my classmate, Dr. Christina Bove. So that's pretty cool. And secondly, this is going to be a complex cardiac condition article. There's a lot of stuff in here that's going to be presumed that folks who are watching this know. I'm going to try and explain the basic stuff as much as I can. And some of the stuff even goes over my head because it's really geared towards like cardiologists. But we'll do the best we can, and hopefully those who watch on the playback and live will learn something from it. So this comes from JAVMA, like I said, it's the ECG of the month. There it is. And we'll get started. The story is this older Labrador had emergency abdominal surgery for gastric dilatation and volvulus. And then after 2 days of being home from the hospital, got ill, inappetence, lethargy. And the vet who referred the case to this institution where Dr. Bove works ran an electrocardiogram, which found some arrhythmias. Now, right off the bat, I have a video on GDVs, gastric dilatation and volvulus, on my channel, so feel free to look at that. I have lots of 1-hour lectures on this topic as well. I give this talk nationally. And heart arrhythmias are one of the most common complications of that disease, of that surgery. It's multifactorial as far as what the causes are. And so it's not the surgeon's fault necessarily, or anesthesia or anything like that. It's just the nature of having a severe condition like GDV. Any condition that is that severe that causes systemic effects can cause heart arrhythmias. So they ran the ECG, electrocardiogram. Now, ECG looks at the electrical function of the heart. An echocardiogram, or an echo, is ultrasound of the heart. That looks at the actual structure of the heart. And so those are two differentiating factors here. One does not replace the other. They are complementary. And so most of the time an ECG is done first because it's cheaper, it's more widely available, it requires minimal training, let's say, to see if there's something abnormal there. Whereas the echocardiogram, the ultrasound, requires a special machine, extensive training, lots of practice for that. So usually an ECG is the first line of defense, especially if you're hearing an arrhythmia, because for arrhythmias, that's an electrical imbalance in the heart. You want to run an ECG initially. So the ECG found narrow complex tachycardia. So narrow meaning narrow, not wide. Complex meaning more than one constituent to it. Tachycardia means fast heart rate. And we'll show you what a picture of that looks like here in a minute. So they treated with lidocaine, procainamide, merapentine, ranitidine, and diltiazem. We will not go through those drugs unless folks have questions on that. And that was all done at the vet. They noticed that when they listened to the heart, they can tell it was fast. 130 beats per minute for Labrador is fast. They can tell there was arrhythmias. And they also can tell that the femoral pulse quality was good, but there were deficits along with the tachyarrhythmia. So first off, tachyarrhythmia means it's a fast heart rate, and there's also an arrhythmia associated with the fast heart rate. Femoral pulses are the pulse that you can feel in dogs and cats right in the groin area at the very top of their inner thighs. And if you can feel the pulse, then you want to listen to the heart at the same time that you're palpating the pulse to see if the heartbeats are matching the femoral pulse beats. And if you have an arrhythmia that causes a deficiency in blood flow, then you will feel what we call a dropped pulse, meaning there is no femoral pulse, even though the heart clearly beat. It was an arrhythmia though, and because of the arrhythmia, there was no insufficient blood flow to reach that part of the body, and so it resulted in a dropped pulse. A dropped pulse is when you do not feel the pulse. So that's a good indication, even before you run an ECG, by the clinician, that there's an arrhythmia here. Then they had an echocardiogram done, so that's ultrasound of the heart, and they found left ventricular dilatation. So the heart has two atria, which is plural for atrium, left and right, at the top of the heart. And then underneath both of those chambers are the ventricles, left and right. And so this is saying that they found left ventricular dilation. So the left ventricle chamber was enlarged. And that was the case in both diastole and systole. So diastole is relaxation of the heart during contraction. Systole is contraction. Okay. They also found the left atrium diameter was a bit increased as well. They do comment on the echo that there was a depressed fractional shortening. Fractional shortening is the percent change in heart muscle length during function, during contraction. And a depressed shortening means that the heart is not contracting as strongly as it should. Fractional shortening is the big number that the doctors want to know. There's a bunch of measurements that they'll collect during an echocardiogram, but the fractional shortening seems to be what's the most indicative of cardiac function. So they ran a 6-lead ECG. 6 leads meaning there's 6 different points on the patient that are connected to the ECG machine. And they found what are called premature ventricular complexes, PVCs. And so we're going to show you here what it looks like. I'll try anyway. At the very bottom, where is it? This right here. Let me see. Here it is. Here it is. Here it is. Right here. Those pound signs. So if you notice right before, this is a normal sinus rhythm. This one's also normal, but then the ones that pounds look different. And so you can see that it's considered a premature because it's happening really close to the first one, and it's a ventricular because it's an abnormal shape. It's not the same sinus rhythm. So sinus is what we call the normal shape of the heart pattern, heart electrical pattern. And if it's not normal, then we try to characterize what that might be, and of which there's a bunch of them. And so then what you're also noticing there at the bottom, all these here, these are all the narrow complex tachycardia that you're seeing. So you can see that there's a whole bunch of them, meaning that it's a fast heart rate. They're narrowed, they're not wide, and that's indicative of narrow complex tachycardia. And it seems that in this case, if you notice that at the VPCs, the premature ventricular complexes are happening right before the patient was triggered with the narrow complex tachycardias. So the where is it here? The PVCs happened first here with the pound sign, and then it created here, right here, and then it created all the tachycardia. Oh, electrical alternans. You can also appreciate here that there's sort of at the very top of these rhythms, it's like an ocean wave, up and down, up and down. That's called electrical alternans. That's when there's alternating heights of the heart rhythms. All right, so they started treating the dog at the specialty center by Dr. Bove. Sotalol, pimobendan, mexilatine, and again, we won't go over those drugs here unless folks have any questions. So now they go into the discussion. So this is where there's going to be a lot of terminology here, but it's important, especially for those who are watching this that are vet students or newer vets. Even for someone like me who's seasoned, this is a lot of information, but we're going to go through it. So supraventricular tachycardia represents a broad category of dysrhythmia. So I'm not sure why the word dysrhythmia as opposed to arrhythmia, but either way, either term implies an abnormality from normal heart rhythm. Supraventricular tachycardia. So supraventricular means above the ventricles. We mentioned before there were the two atria above the ventricles. Any structures above the ventricles is considered supraventricular, as opposed to the alternative, which is ventricular. And tachycardia we already described as fast heart rate. So supraventricular tachycardia represents a broad category of dysrhythmia that includes rhythms emanating from the sinus node, atriomyocardium, atrioventricular, and junctional tissues, as well as accessory pathway mediated tachycardias. Okay, let's go through all that. The sinus node is the node in I think the left atrium that is thought to be the initiator of the electrical function in the heart. That's what starts everything. Atrial myocardium. The atrium, like we already mentioned, the two atria on the top of the heart. The myocardium is the muscle of the atrium. The AV and junctional tissues. So the AV nodes, atrioventricular, so right at the junction of where the atrium and ventricles meet. There's a node there, and it's thought that after these electrical pattern from the sinus node travels down the atrial myocardium, it's going to then hit the AV node, which then sets the signal for the ventricles. The reason why there's these nodes, by the way, is to keep the heart on pace, right? Let's say you have a disease in one of the nodes, you hope that the other node will be a gateway to protect that arrhythmia from propagating to the rest of the heart. It's very cool. Okay, so basically supraventricular tachycardia can happen from anything above the heart, and we just mentioned a bunch of different locations. Now, you can divide supraventricular tachycardias into regular and irregular. Regular includes a bunch of different types. So regular includes focal atrial tachycardia, atrial flutter, AV nodal reentrant tachycardia, and AV reentrant tachycardia. Those are all the differentials. That's more for the cardiologist. We're not going to go through those. The AV reentrant tachycardias are caused by bypass tracts or accessory paths in which conduction can be anterograde, retrograde, or both directions. Again, that's for the cardiologist, but just to show you how complex this can be. So first you diagnose supraventricular tachycardia, then you say, okay, is it regular or irregular? And those are all the causes of regular. Irregular causes include atrial fibrillation, atrial flutter with variable AV block, and multifocal atrial tachycardias. We'll leave those alone. That's just to give you differentials. If you're a vet student listening to this or a new grad, and you have a strong interest in cardiology, you can list those differentials. All right, let's see here. Yeah, and that's it. The rest of the article goes into more minutia. That's more for cardiologists. But the dog ended up dying 11 months later. He was doing well, and then suddenly passed away. And I suspect anyway, it doesn't mention it in the paper, I suspect that probably the dog had a lethal arrhythmia. That's my guess. It could be any number of factors, and a necropsy wasn't performed, or at least assuming based on this article. But one of the things I warn owners about with the dog that develops arrhythmias, most commonly in my case during or after a surgery or before a surgery, is that despite our best interventions and monitoring, the pet can have a lethal arrhythmia. It's the same thing when you hear about like an athlete that's young and healthy that all of a sudden dies from an arrhythmia. It can happen randomly, and so the dogs that have a known arrhythmia are more likely to suffer from that. But from what I can tell, at least, if it does happen, or if it has to happen, I guess, it's a pain-free way to go from what we can tell. So not a bad way to go, but still a shame regardless, because it sounds like these people did what they could for this pet. All right. Well, I hope that helps. It's a lot of information, and I imagine folks who are interested in that information will probably pause the video and rewind it just to write down all those differentials. Very interesting stuff. We'll do another article again tomorrow, September 26th. Thanks for everybody who watches on the playback. Bye.